capturing how patients actually feel, their symptoms, their function, their quality of life, is one of the most important and most tedious parts of clinical research. Patient-reported outcome measures are the standardized questionnaires that do this, and developing one can take years. So here's the question. Can large language models speed that up without breaking the science? A commentary in the Journal of Patient-Reported Outcomes says yes, but only with humans firmly in the loop. Right now, building a patient-reported outcome measure is painful. You're looking at years of qualitative interviews, item drafting, cognitive testing, and psychometric validation. That's testing whether the questionnaire actually measures what it claims to measure. Each step is slow, labor-intensive, and expensive. The question this commentary addresses is whether large language models can safely accelerate any of these steps without sacrificing the validity that makes the measure useful in the first place. The authors identify 5 bounded use cases, and each one is deliberately narrow. Domain cartography, mapping out the different aspects of a health condition from existing research. Item generation, drafting large candidate banks for expert review. Cognitive interview support, simulating patient interviews to spot confusing wording. Semantic coherence checks, catching duplicate or unclear items across the full set. And developmental adaptation, adapting measures across languages and populations. The key principle: LLMs assist, never decide. But there are real risks here, and they're subtle. Confirmation bias. LLMs may reinforce existing frameworks and miss novel constructs that actually matter to patients. Semantic circularity, when AI-generated questions look right on paper but aren't grounded in real patient experience. And construct drift, when repeated AI passes quietly shift what the questionnaire is actually measuring. These aren't the kind of problems that show up in a superficial quality check. So what's the safeguard? The authors propose a human-in-the-loop roadmap. Human oversight. Domain experts validate every LLM output before it enters the pipeline. Model triangulation. Use multiple LLMs and compare outputs to reduce single-model bias. Bounded scope. Limit each LLM task to one specific step, never full measure development. And a patient anchor. Ground every item in qualitative patient data. The roadmap keeps humans as the decision-makers at every gate. Caveat: this is a commentary proposing a framework, not an empirical validation. But the core message is clear. LLMs can be useful tools in the Pro Toolkit, but only with explicit guardrails, human judgment, and patient grounding. If this kind of translation is useful to you, take a second to like and subscribe. It really does help. And catch Healthcare AI daily every day on the channel.